Hi, so welcome to this series of lectures looking at the nerves of the lower limb. We're going to do this slightly differently to the series on the upper limb, in that we will group some nerves together, and there's a reason for this. Three of the nerves that are clinically very relevant, the sciatic, peroneal or fibular, and tibial nerves are really all the same nerve. So I'm going to deal with all three in one slightly longer lecture, which is the first lecture. And then at the very end, there are some less important nerves which may be associated with very specific clinical syndromes, and I'll deal with those as a group as well. So let's go. So here's our first case, a 38-year-old female who presents to the emergency department with a foot drop. She received an intramuscular injection of diclofenac 1 week prior. Pause the video, see if you can figure out what's going on here, and then we will talk about the nerve involved. So as usual, what nerve is involved? What's the anatomy of that nerve? What are the clinical features of a nerve injury involving that nerve? So this is, of course, the sciatic nerve. The sciatic nerve is formed from fibers from the lumbosacral plexus, L4 down to S3. And it's really the nerve of the lower leg, that is, everything below the knee. Both muscles and actually a lot of the sensory innervation as well. The nerve forms from these fibers from L4 to S3. It passes in front of the piriformis muscle in the pelvis and then leaves the pelvis to lie behind the biceps femoris muscle and and then emerge from behind the biceps femoris into the popliteal fossa, where it divides into its two main branches, the tibial nerve and the common peroneal nerve. The motor function of the nerve includes the posterior thigh muscles, the biceps, so the flexors of the hip and the flexors of the knee and extensors of the hip. So the biceps femoris, semimembranosus, semitendinosus, and adductor magnus. And as we said before, all the muscles below the leg. And it supplies the foot and lateral leg through its tibial and fibular branches, which we'll discuss later. Here are some common injuries that may occur to the sciatic nerve. It can be damaged during IM injections, and it actually lies medially and more inferiorly within the buttock area. So the classical way of avoiding the nerve is to divide the buttock into 4 segments and make sure you give your IM injection in the upper outer segment. Another way of doing this is to find the posterior superior, the iliac crest. Place your hand on the posterior superior iliac, just below the posterior superior iliac crest, or section of the iliac crest, and then anywhere under your hand would be safe, which is the upper outer quadrant of the buttock. It's also at risk during hip dislocation because the posteriorly dislocated hip will press against and stretch the nerve. And of course, we need to think about the effect on the nerve of compression of the nerve roots which form this nerve through disc prolapse or piriformis syndrome, which is compression of the nerve as it passes below the piriformis muscle. And the clinical features are what you would expect. weakness of dorsi and plantar flexion of the ankle, leading to a foot drop, and loss of sensation to the lateral leg and foot. Sciatic pain radiates down the leg and can be aggravated on stretching the nerve during the straight leg raising test. So here's another case, a 32-year-old female patient who presents to the emergency department 2 weeks after sustaining a fracture of the tibia because her cast is too tight. On removal of the cast, the patient is noted to have a foot drop. Again, stop the video, think about what nerve is affected, and then what clinical features might be involved. The anatomy of the nerve and what clinical features might be involved in such a nerve injury. So this is an injury of the common fibula or common peroneal nerve. This nerve is formed as the lateral terminal branch of the sciatic nerve in the popliteal fossa. It passes out of the popliteal fossa behind peroneus brevis and winds its way around the neck of the fibula, then dividing into the superficial and deep fibula or peroneal nerves. The superficial peroneal nerve lies between extensor digitorum and peroneus brevis as it goes down the leg. It's initially deep to the deep fascia and then penetrates the deep fascia and supplies the sensation to the skin on the lateral aspect of the leg and the dorsum of the foot. The deep fibular nerve passes deep to the anterior muscles of the leg, lies on the anterior to the the tibiofibular fascia, the interosseous fascia, and supplies the muscles of the anterior compartment of the leg. So the motor supply of the common peroneal nerve is the short head of the biceps and the lateral and anterior compartments of the leg, and its sensory function would be the lateral leg and the dorsum of the foot. So all of the anterior and lateral compartment muscles will be supplied by the deep peroneal nerve. The nerve may be injured with a fracture of the fibular neck or a tight cast where it winds around the fibula. And of course, this will cause numbness to the foot and the foot drop. It does have a superficial branch, as we said before, and a deep branch. And you can have a look at this and see the exact muscles that are supplied by both the superficial and the deep branch and the sensory supply to each of these areas. And then finally, a 22-year-old male patient who has been shot behind his knee and he's unable to plant affects his ankle. Again, stop the video, think about which nerve is affected, think what you know about the anatomy of this nerve, and also the motor and sensory supply, and therefore what clinical features might occur with a nerve injury involved here. So this is a tibial nerve. I'm going to just, So the tibial nerve is the medial terminal branch of the sciatic nerve. It passes out, it's in the popliteal fossa and then passes out of the popliteal fossa to lie between the superficial and deep layers of the flexor compartment. So it lies between soleus and gastrocnemius. Popliteus and gastrocnemius. And it supplies all of the muscles of the posterior compartment of the leg, both the deep and superficial compartments, and all of the intrinsic muscles of the foot, except for extensor digitorum brevis, which is supplied by the deep peroneal or tibial nerve. It supplies sensation to the sole of the foot, and also it contributes to the sural nerve, so it can supply some sensation to the posterolateral leg and the lateral side of the foot, lateral edge of the foot. Any penetrating injuries to the popliteal fossa which can cause tibial nerve damage and may be associated with arterial injury. And any disruption to the knee, such as posteriorly displaced knee location or displaced supracondylar fracture, can also put pressure or compress the nerve and cause injury. As you would expect, the clinical features of a tibial nerve injury include numbness over the sole and loss of plantar flexion of the ankle and toes. So, as I said, this first lecture was a little longer, carried you through the sciatic nerve and its two important terminal branches. In subsequent lectures, we'll look at other nerves of the lower limb. If you have any questions, you can bring them up in class. As usual, thank you for listening.